Hello, everybody. It is 5:30. The long-awaited Alchemy Clinic female hormone event is finally here. We are so excited to be here tonight to share with you all of the things about female hormone replacement. This is really a it's a talk that was really truly designed for you. So, if during any of this time you have any questions, please feel free to write it in. We will be able to answer any and all questions that you have. This is just a way to sort of review some of the hormones, some of our most vital hormones. Why are they important? Not only for helping us with acute symptoms, but helping us with more of the long-term benefits that we will inevitably gain from utilizing hormones. And so, without further ado, I'll give people just a second to log in and to come on. But again, we're really excited to do this. This is it's such an important topic that we have grown to really love and master in our own practice here. And so let's get started. So the hormone buzz, why all the talk? So I don't know about you, but a few years ago when we started hormone therapy, there was interest, but now there's really come to be more interest in this topic. And that's because there's just more talk about it. We are becoming more comfortable understanding these tremendous changes that are happening in our bodies. And we no longer have to be quiet about it. We have treatments to really help us with this. So hormone therapy is definitely not a new concept. Hormone therapy came about in the 1940s, that there was an FDA approval for hormone therapy at that time. And this was really the use of synthetic hormones at this time. And Erin's going to go into the difference between bioidentical and synthetic. And so for many years, we were using these synthetic hormones up until really 2002, where the World Health Initiative came out with this very large study that quite honestly scared a lot of people away from using hormones, not only patients, but providers alike. And so sort of, put this into a bite-sized bits for you to understand what this WHA study showed was that women, they proposed that being on hormone therapy had women were at greater risk of developing cardiovascular disease, stroke, and even the development of breast cancer. And what we found, now that there was years to reflect on this study, is that the study was poorly designed. And what they sort of didn't necessarily come out and say is that this was really with something called Premarin and progestin. So these are synthetic forms of hormones that it was causing. And it was also in, women that were 63 and older. So, we've now spent a lot of time reflecting on different studies, and we now know the safety of utilizing hormones. And we're going to talk about that because there's so much more research that's happening vastly every single day that we're learning about. And so we're going to get into it because this is what you're here for. Okay, Erin. So everyone that's here is probably having some sort of feeling that there's something going on in their body. Maybe you're having some symptoms. And what we really need to know is that it is normal to have these fluctuations in our body as we age. And I think what we really want to look at is, as we age, do we want to feel these symptoms, and do we want to be more healthy and have that all-cause mortality decrease as we add our hormones back into our body? So hormones are just chemical messengers that regulate our body to do something. So we know that estrogen, progesterone, testosterone all have major functions in our body. Mm-hmm. And that's really what we're going to go look into, and how this havoc in our bodies in perimenopause and menopause, how we can really make you feel better. So, need to know hormones. What do we need to know?
Well, we need to know quite a bit. But first, estrogen, right? So, estrogen is that dominant sex hormone in women that we need. And when it gets low, we are very symptomatic with, but it can protect our bones, our heart, our brain, and even can improve our skin elasticity.
Yes, this is a big one when we talk about like, in the world of aesthetics. Estrogen is a vital one that plays a big role when we do hit menopause. That we see a lot of changes within our skin and elasticity.
And for those that are going through something right now, you don't really know exactly what it might be. The next one, progesterone, okay? Huge in perimenopause and in menopause and like postmenopausal, but this is the one that is really causing those sleep interruptions, right? Because we are losing our progesterone before our estrogen. So when we get progesterone back, we are balancing out that estrogen dominance. When estrogen, we have more estrogen than the progesterone, where it really helps calm those GABA receptors and help us sleep. And I say this to Jen all the time, it's nature's Valium. Like,
Yeah.
it is amazing.
And it can really be a game changer for women, and we'll talk, and Erin's going to share her experience later through her own hormone journey. But when we're not sleeping, our entire lives are disrupted. Sleep is so important for healing, for the vital cellular repair. And so when people feel like, oh my gosh, I finally got a good night rest, that can make or break an entire day, right?
And then look, if you're looking at testosterone, you're like, what's testosterone? What do women need testosterone for? Well, a lot of people complain about, I don't even want to have intercourse anymore. I have no libido. There's nothing there. I just have zero interest. Well, that's your testosterone going down, right? We need a little bit of testosterone, like men need a little bit of estrogen. But not only with libido, it's also going to boost your mood. It's going to boost how much energy you have. It helps maintain our muscle mass. More importantly, the studies have shown that it decreases fat mass. So testosterone can be a game changer in hormone replacement therapy. And it's sort of like a newer thing that is becoming more mainstream, but is not highly studied in women.
Right. And I think for a long time, there was never this knowledge that, it has become a newer understanding that women have just as many receptors for testosterone as men do. Obviously, we have about 1/10 of testosterone, but it is a vital hormone. And it's even, even in perimenopause, by the time a woman is in her early 30s, we've already lost about 50% of our total testosterone that we have. And that brings us into DHEA. So DHEA, I just wanted to sort of put in here. When you think about hormones, everything starts out as cholesterol, and in a really difficult pathway, everything is sort of broken down. And DHEA is a precursor to the development of forming into testosterone. So for maybe a younger patient or a woman who is in perimenopause where those levels are low, but we maybe don't necessarily need full on testosterone replacement therapy at that time, DHEA is a great vitamin or hormone to replenish. And it's not only imperative for when we think about our reproduction or sexual function, but it's also really important for cognitive impairment, or excuse me, to maintain cognitive function. So even if your testosterone is normal or you're maybe on testosterone therapy, we may also be adding some DHEA because that's really, again, vital for cognition. So the roller coaster ride, we've already sort of spoken about this, but for a lot of women, people do feel like you are on a little bit of a roller coaster. And perimenopause can start from either 8 years to 10 years prior to even hitting menopause. And everyone is going to be on a spectrum. Your journey is your own. My journey isn't going to be the same as even my twin sisters or Erin's. We're all going to be sort of different, but it's just important to understand that you're going to be on that journey somewhere. There are going to be some women that might enter into these phases and they sort of feel maybe a blip in the road, or maybe it really wasn't, they don't really feel a whole lot. Whereas other people, it is a very drastic change, and they're really noticing this. And so it's our job here is just to sort of be along for the ride with you when you're on this journey.
All right, our symptoms. And we've touched a little bit on some of these symptoms, but as you can see by the slide, it is not just hot flashes,
Yeah,
right?
and I think that this is a great point, Erin, because I think a lot of us we just think that it's one specific thing, and if I maybe don't have that, then maybe I'm not in menopause, or maybe I don't not going through this.
Right. And it's so interesting to hear from like perimenopausal and postmenopausal women when they say, I think I'm going crazy because I have never had depression and I'm so
Or
depressed.
anxious.
Or
I'm so
so
anxious.
anxious. And this is really a loss of your hormones. Again, brain fog. And I describe brain fog as kind of feeling like cobweb. You can't really like remember why you went into the room or you were going to say something. Brain fog, right? And
Yes.
so these things are all quite normal kind of symptoms of hormone loss, but they don't have to be.
But they don't have to be.
Right?
Right.
You don't have to live with it.
And, again, cardiovascular, and we're going to talk about this, but when a woman is entering into menopause, it's very common we see this time and time again, where we'll check some vital signs or you'll check someone's blood pressure and all of a sudden blood pressure is increased. Or maybe
And they've never, I've never
which
had
is
high blood
which is
pressure.
yeah, which is entirely new. Or maybe you've had some labs done and now your lipid profile is now escalating. So estrogen is really protective for our cardiovascular system. And so it's not uncommon to experience palpitations, blood pressure changes, hot flashes, etc.
And people going through like massive workups for these. And it's really like when it comes down to it,
Yeah,
I didn't find anything for your palpitations. Well, yeah, it's your menopause, right? Another thing is our digestive systems can really become sort of have some havoc wreak on them, right? We notice that we're gaining weight. We might feel bloated. Some people say, oh my gosh, I've never wanted to eat so much in my life.
Yeah.
Or I have no appetite. So these are all hormonal imbalances.
And that sort of even goes into the endocrine system in that we tend to experience more metabolic changes where, maybe you're not necessarily, your labs are not consistent with you being a diabetic, but we're developing more insulin resistance. We're sort of trying to do the same things. We're exercising, we're eating well, and we're not getting the same, we're sort of like running up. It's like just being on a treadmill, like you're running uphill all the time. And then thyroid issues. So, understanding and evaluating the endocrine system when we're also evaluating hormones is really vitally important so that we're not missing these other pieces that can sort of start to unravel a little bit as well.
I think one huge sign that people see, Jen, when they complain, I think like maybe something's happening here, are those irregular periods, right?
Yeah.
So they're going really short time in between their periods, really long time in between their periods, or they're having super heavy periods, like bleeding through everything. This can be, signs of that fluctuation. Again, that decreased libido, right? Not feeling like you have that desire to want to have intercourse. And then when we look at the perineal area or the vaginal area in general, like things can start to get dry. We start to lose like volume. It's just, and the integrity of the tissue can start to sort of get more fragile. That might lead to painful intercourse. That might lead to urinary frequency, urgency, frequent UTIs. So it's all of that kind of genitourinary system can change when we start to lose those hormones.
For sure. You have to remember that there's estrogen receptors throughout our entire body. And so it's not So when we're breaking this down into systems, it sort of starts to make sense, right? That yeah, my urinary system is going to be affected, or talking about our musculoskeletal system. Estrogen is so vitally important for the production of collagen and the production of hyaluronic acid. And yeah, that's great when we think about aesthetic purposes, but when we're also thinking about the musculoskeletal system, when we start to have aches and pains, or our joints are starting to hurt us, or we're having like back pain that just doesn't necessarily seem consistent. Like there was no necessarily any injury, but that's all because that estrogen is so vitally important for making sure that those joints are sort of nourished there, that when we start to lose that, it's not normal. Like we're trying to sort of push and drive home that this doesn't have to be our norm of having pain and discomfort. So the heart disease reality, heart disease is still the number one cause of death for both men and women in the United States. And in perimenopause, 1 in 7 women will have heart disease or be diagnosed with heart disease. But when we transition into a menopausal state, those rates increase drastically to every 1 in 3. So it's really important to drive this home that it's not only the benefits of maybe I'm going to have some hot flashes go away, etc. It's not those acute things. It's really more thinking about the long-term benefits of how am I protecting myself and my body against the development of cardiovascular disease, diabetes, metabolic issues, osteoporosis, dementia. There are so many things that I think it's just so important to make sure that we're really focusing and owning in on that. What do you think, Erin?
Yeah, agreed.
Okay, so let's just talk about types of hormones. Like we hear about this all the time. Does it really matter? Let's get into it.
So we have two kind of categories. We have bioidentical and synthetic hormones. And what does that mean, bioidentical? So bioidentical is just that. It's the exact molecule that mimics our human molecule. So for example, bioidenticals are typically derived from the yam plant is a great example.
Mm-hmm.
Okay. So they derive the sterols out of those cholesterols out of the yam plant. They sort of change that into whatever delivery system or whatever hormone we're making, progesterone, testosterone, estradiol, and make it into a delivery method, cream, pellet. We're going to get into those in a minute. So what it really is, why it's really important is because it's the same as our own molecules. We can kind of think of it as a lock and key.
I think that's always a great analogy. Because I always think about something, if it looks exactly identical to that, it's going to fit exactly there.
Right. It's going to unlock the right things in the right manner versus synthetic hormones, which can be derived from, they can either be molecularly synthesized, like in a lab. They can be derived from animals. So conjugated equine estradiol is a great example of that.
And this is essentially what was in that old WHI study. Is they were referring to this conjugated estrogen, and when it's coming from a horse and it's coming from an impregnated horse, there is not only estrogen that looks identical to the estrogen in our body, but you have all these other estrogens within that. And so what happens is when it's locking into place, all of that other estrogen has to go somewhere. And essentially we worry that it's inevitably going to go down a wrong metabolic pathway that can potentially predispose us to cancer risks, etc. It sort of increases that. So,
and synthetic hormones we can use very safely as well. I think birth controls are synthetic hormones, right?
100%.
And we're not seeing a ton of women getting breast cancer from birth controls, right? And I think the big thing about the synthetics are, and what I want to kind of like point out, it's like kind of as we age, they become a little bit, it's a little bit harder to synthesize those metabolic pathways with the synthetics.
Yep.
Now, synthetic hormones come in many different delivery methods, so pills and patches.
And I would say, I mean, predominantly, I think we use a lot of preferably we like to use bioidentical hormones. It's again, because I sort of in my brain just think of it as being a little bit cleaner. If we could deliver something that is less extra things I have to worry about, then when you're thinking about replacing someone and having someone be on this for extended periods of time, and I'm talking years, right? That I personally want something that is just in a better form. So let's talk about some delivery systems. So in our practice, we will use just about anything and everything, because again, no patient is a one size fits all. What is right for one might not be right for another patient. So first, oral, we will give a lot of oral progesterone. Progesterone is a pretty large molecule. You can do topical hormones, or you can do an insert or a vaginal insert. But I think most of our patients are on oral progesterone and they do really well. You can deliver estradiol orally, although I tend not to use this a whole lot. In the right patient, it could be fine and safe, but I guess there is a very small theoretical risk that could this potentially increase rates of developing clots, etc. So if we can use it in a different form, I would maybe prefer to do that. Oral, you just have to remember to take things every day, so that's one downside of taking something orally. For men, there is an oral testosterone. We rarely use this. It's associated with adverse side effects and hypertension, and so we just don't do that. We just don't use this a whole lot. Transdermal and creams, we do use a lot of. So there are some upsides when you're using a cream. You have a little bit more ability to titrate doses according to the patient. You can compound doses that are very specific to what we want our patients to have, which is also really important, because sometimes when you are getting something that is maybe synthetic or that comes in just prepared doses already, we can't dose adjust as as organically, I guess, for that patient. The few downsides, however, of using something transdermally is that you have to do it every single day. So you have to do that every single day so that you have that steady state. You have to be using it correctly, meaning you have to be making sure that you're rubbing it in for at least 30 seconds, because the pressure of you rubbing it into your skin is helping that actually get into the skin. And there can be some variability, because my skin might be different than Erin's skin, right? So if someone has maybe more oily skin versus dry skin, maybe they've had a lot of sun damage, all of these things are going to sort of come into play. So sometimes people might need to switch to another method if they're not getting, if they're not feeling, or if their levels, and we're going to talk about levels with transdermal. It's not necessarily apples to apples. So when you're checking labs, we do a lot of labs where we're doing blood draws. It's very important to know what your baseline labs are first and foremost. But when you're utilizing a cream, that cream is essentially going into your lymphatics. And so your more or less your levels are, what am I trying to say, Erin? Like, not the byproduct of that, but it more or less is. You're not necessarily getting like a 1-for-1 level dosing. So when we're checking levels on you, it's really to ensure that your levels are not too high when you're utilizing a cream. I don't expect levels to really change drastically. I just don't want them too high, or else we would have to then lower the dose on a transdermal cream. I think that's where some providers get a little, where they keep trying to higher the dose, thinking that you're not seeing enough of that higher level, whereas you're not necessarily going to see that in a cream. So anything to add to that, Erin?
Well, I think
sort of beat that to the bush.
If you are going to be a purist in this, a lot of if you follow a lot of people on social media about hormones, are going to say the only way to check hormones is saliva or dried urine. And this is with testing. And here's my take on that. Yes, like we can do all of that testing. Yes, it tells us a lot of information about metabolic pathways. I think the ability to get this in a timely manner and in a cost-effective way is can be challenging.
So I think there's that balance.
Right.
And if we really, really, really wanted to know the levels on a cream, then I would say, yes, we can do swabbing, but we would just probably have to have at least 2 or 3 of those swabs to sort of make sense of that, because we always start with blood testing initially. But again, we have tons of patients on transdermal cream. They do really, really, really great. We're using those levels as a tool. It's not necessarily a direct guide as to changing doses. It's going to be more for how are you feeling? Are you having any adverse side effects? And that's sort of how we guide and change that.
And so another way to delivery method for the hormones in terms of testosterone and estrogen are injectable forms. And I would not say in women this is the most common, although we do have some women that are on injectable testosterone. I think the upside of this is that we can titrate the dose very quickly, right? The next dose, we just go up, we go down. You can feel a little bit either roller coaster like, or some people just feel like that is getting them at a steady state.
Right.
Men do more of a bi-weekly injection, whereas women are doing weekly, because the testosterone lasts a little bit longer in women than in men, so that we don't have those big fluctuations. What else can I say? Some of the side effects, right, of of injectable. It can lead to some of those more adverse reactions of aromatization, and that's just a fancy word for your testosterone is converting into estrogen. This is how men get a lot of their estrogen.
And this is a normal thing
process
for both females and males.
Right.
Down that complicated pathway, some of our testosterone is inevitably turning into estrogen as well.
Yeah, and that can, and I think with testosterone injections, I think we see this at a higher rate than with, say, transdermal or even the pelleting. And we can always go through some of those in a consultation, some of those sort of things that can happen when you take injections or testosterone injections.
Yeah.
Another great way, and Jess and I love our pellets. We love pellets. So pelleting is when we place a small little pellet. It almost looks like a rabbit food.
Yeah.
Women get 1 or 2 pellets. It can either be testosterone and estrogen. Again, you're getting your progesterone likely orally. We don't have progesterone, unfortunately, to pellet. But this goes in underneath your skin. So typically in the upper outer buttock area is the most common area. It is a procedure, mostly painless. I just think the lidocaine.
Yeah, it's definitely very tolerable. For sure.
Yeah.
For sure.
And this most women will pellet anywhere between 3 and 4 months, depending on your levels, how you're feeling, etc. I think the positive thing for pelleting, it's a set it and forget it, right?
Yeah. Yeah.
And so for people who are not going to do every day and are not going to want to inject, this is a great.
Yeah. And for sure, the convenience factor. And again, I think we're just it's really important just to understand that, there are so many ways, and, and some people, and we have a ton of people that pellet, but for some people that they might just not do well with pellets, or we might just have to,
or their cardiac output is so high, they're cranking through those pellets.
Or maybe they've been really sensitive to any type of hormones in the past, maybe even just birth controls or different things in the past. So we might then want to start with maybe something topical, something that we have the ability to pull off very quickly, rather than having something in a pellet form where it's going to stay there. It's not, once it's in there, you're not necessarily going back to retrieve that. So, there's pros and cons certainly to all methods.
And I would say I really like to reiterate that when you start this hormone journey, this isn't a 1 month and I'm not feeling anything. This is, I tell people, we're committing
Got
to
to give
this
it some time.
for, I like to say, like, this journey, we're going to get a year before, like, we know what's working for you and what's not working for you.
And you know, it's interesting because I think I just wanted to point this out is that a lot of times there, and it's really always great to have people do some, charting what your symptoms are even prior to starting, because sometimes when you've been on that for a while, you sort of now, you had a norm, we now have a new norm, and then we forget what our old norm was. And so what I have found with a lot of patients is when they have then stopped, that maybe they're like, you know what, I'm just going to sort of come off hormones and just see how I feel, which is totally fine. That's really when people, they're like, wow, I now really know what I felt like, and I don't want to go back there. And so it's sort of back onto that. So I think everyone's journey is going to be different. You can't compare your journey to somebody else. That is 100% for sure. But just giving it time, because our bodies didn't get here in a day. Okay. We've had maybe years of this progression as to where we are, and it might take some time to get us back up to where we're like, okay, we're feeling really good. So some key considerations. So first and foremost, whenever you're considering having hormone therapy, you need to have a comprehensive evaluation. It's so vitally important to review your medical history, symptom evaluation, and then doing really a risk evaluation, which is going to include family history. We will do some scoring to help us identify risk factors as well, because you really just need to understand your patient so that we can then guide therapy appropriately. So it's not only that piece, but then it's that the lab piece. And we don't just do hormone labs. We'll do further extensive labs, more of that holistic functional medicine piece, because we want to ensure that we're not missing any of those other pieces. You can't sort of be blindly thinking with blinders on that every symptom that one might be having is 100% directly correlated to hormones. Yes, there's a lot of symptoms that are related to hormones, but you have to, that we're much more, our bodies are much more complicated. We need to make sure vitamin D levels are good, our thyroid levels are good, what's going on with our cardiovascular panels, what are all of those things. And even Erin does a lot of gut health here in the office. It's sort of collecting all of those pieces and then making a plan so that we really truly can optimize your health as much as possible. It's not sort of piecemealing these things together, because when we piecemeal, that's, I think, when we don't always feel 100%. What do you think, Erin?
I agree. Totally agree.
And when people are piecemealed, you really feel like there is something that is vitally missing in the picture. Okay, myth busting. Here we go.
All right. So, age limits. You can be older and you can be even a little bit younger, and we can really start on hormone therapy.
And give us an age. Like when you say younger, older, like what is it?
Here's an example. I'm 65 and I've been menopausal for 15 years. Can I start hormone therapy? Yes. Now, will you have the same health benefits as a 48-year-old woman who is right before menopause? No, because they've already got,
because they've already beat you by how many years of being on,
right? Being well, right? So we're kind of preventing the prevention, sort of the more health benefits you get there. But from 65 on, you're still going to gain some health benefits
100%
from hormones.
And I always say it's like sort of seeing where you were, and then it's looking at where you are in that time. So say there's maybe we're trying to gain some muscle, we're trying to reduce our, osteoporosis risk. Well, yeah, if we start on testosterone therapy, we're sort of stopping that at that moment, and things are not going to get worse. And we hope that we can get better in that time. So I think there's sort of different ways to think about it. And again, calculating risk factors. If we're older, if a woman hasn't seen estrogen for 20 years, then we have to be careful. We have to be careful and really be very thoughtful with what we're implementing, what we're doing, what those risk factors are. But that doesn't mean that we can't, that a woman who is more mature we can't consider them for hormone replacement therapy.
And I think likewise, early on in perimenopause, when you think like there's no way that I would be able to do hormone replacement therapy, I think that's like, yeah, we can. We are going to choose like the right hormones for you. You're not, if you're still getting a period, you're not going to do estrogen.
Right.
But we can kind of tailor your therapy with certain hormones.
Right, for sure. And then the big one is cancer concerns. So this is a big one because again, I think that a lot of people have been jaded over time with this realization or this thought process that hormones equal cancer. And that's not true. Every physical body is going to be different. What I like to say to this is we do our risk factor evaluation. You have to evaluate that first. If people have high risk for cancer, then we have to be really judicious about what we do and how we move forward. When women are on hormone therapy, that doesn't mean that you are now at an increased risk of developing cancers. This just means that we have to just be mindful. We want people to be getting everyone should be getting a mammogram every single year, whether that be hormones or not, but specifically if you're on hormone replacement therapy, that should be in your plan of care. That's just that's our rule, okay, in practice. Everyone should be getting their colonoscopies. That's just normal. And this is everyone in general should just be getting that preventative health. But yes, our bodies, we may have some environmental predisposition, some genetic predisposition that we didn't know about. And there might be at some point a development of that. And if that was the case, then we might have to then reconvene and reflect on whether or not people are going to stay on hormone replacement therapy. But it is really, truly, and those risk factors are who in your family, in your immediate family, meaning parent or sibling, that is immediate risk for do we halt? Do we have to sort of recollect and reconvene? And if we're going to move forward. But I think, again, everyone's different, but there is no cause in terms of hormones equal cancer. That is a myth.
Another myth is I'm going to gain weight if I start on hormone replacement therapy. Okay. This is sort of like twofold. You're not going to lose weight specifically on hormone replacement therapy, right? It's multifactorial. We talked about insulin resistance and being a little bit more metabolic. We talked about thyroid dysfunction. So I do think that people who have not had hormones for a very long time, there can be a little bit like water shift, right? In when we start on hormones, there can be. I tell people like you may gain a couple pounds, but I also say please be patient. This is like a 6-month process, right? And then all of those shifts usually resolve as your body becomes more used to the hormones that we are giving back to you.
And I sort of think it's you're putting all of the pieces in place for the patient. So by adding hormones back, we are creating now essentially the perfect environment for us to have more of an ability to gain more muscle, to change body composition, and to hopefully in turn lose weight. Because when we're losing that estrogen, our fat stores, we tend to have a little bit more of those fat stores in place. So just change that shifting, and we're hopefully just allowing the environment to be better so that in fact we can change weight or lose weight. And then heart health. We already sort of drilled this home, but early treatment will definitely protect and provide us with cardiovascular risks for women. Studies have shown that it's really within that sweet spot of those 10 years. So once we hit menopause, whether that is normal menopause, whether that's surgical menopause, those different variables, but hormone replacement therapy can definitely be heart protective for sure. And then a holistic approach. We've spoken about this, but it's not necessarily just hormones that are causing these havocs. Yes, hormones are causing our bodies to feel wildly out of control, but having a plan, a personalized plan to make sure that we are, giving you what you need individually rather than having a set plan for everybody, because it's not going to work that way. My dose and what I need is different than what Erin needs. And we've seen this because we've done this on ourselves. And it's really understanding that you have to take that holistic approach to talking about nutrition, talking about exercise, talking about stress management, sleep hygiene. Do we need to look at cortisol levels? Do we need to ensure that thyroids are optimized? Do we need to sort of look at all of those pieces so that you are also getting the greatest benefit out of therapy, which is really important? So, Erin, tell us a little bit about your own hormone journey, because I think that's really important to get, that picture of how you've been throughout this whole process.
Right. So I'm in my mid 40s. Leading up to my 40s, I was a night shift worker for many years and I did not sleep well. And when I entered into my 40s, I thought that not sleeping well was just like, I work nights. Like, who sleeps well when they work nights? And then I started working here and my sleep should have improved, right? I should have like kind of gradually been able to sleep throughout the night. And what I noticed was like, I wasn't sleeping. I was waking up at 2 a.m., drenched in sweat, right? Not being able to fall asleep. Or if I did fall back asleep, I would wake up again, fall back asleep, wake up again, fall back asleep. So my sleep was really interrupted. And I remember saying, like, weeks in and weeks out, I am so tired, guys. Like, what is wrong with me? The fatigue is real. I get out of bed and I'm tired. I am tired in the afternoon. I'm tired when I get home. I want to go to bed. And then even if I did sleep all night, no energy, right? Then I sort of like recognized that
just going down this journey of should we try this?
Yeah. So we started doing hormone replacement therapy and we started with testosterone. Oh, I should really mention also the brain fog, because I would be like, I can't remember why I said that, or what am I thinking? Who is that person?
What am I getting in this space or this room?
Seriously, it was like for real. Anyway, so we pelleted me with testosterone. And I remember within the first 2 weeks, I had a resurgence of energy, and that fatigue that was making me feel, I mean, I can't even describe that fatigue, was gone literally within 2 weeks. And then my sleep was improved. I would say my energy was better. I was more motivated to do things. As I got more used to the testosterone, I would say that we added progesterone, especially when I was having worsening night sweats. Initially, the night sweats went away with the testosterone, but then they sort of came back a little bit. We added progesterone, and man, that progesterone, it's a game changer. And I'll tell you, our hormones, if you look at when your hormones start to drop off, testosterone sort of starts in your mid 20s and starts sort of diminishing. And by the time you're 40, you get that, like, I don't, please don't look at me, husband. I don't want anything. Right. And then our progesterone,
you're like, oh God,
sorry, hubby. And then our progesterone, as we enter our 40s and into our mid 40s, really starts to rapidly drop.
Yeah.
And our estrogen starts doing this crazy thing like this. And that's when we're getting like all these crazy symptoms. And so adding back a little bit of your testosterone, adding back that progesterone, whoa, what a difference it has truly been in my life. And I will say, and then we'll just move on, when I waited a little bit longer for the pellet, and it just was like, I I forgot when I didn't put myself on the schedule. So I forgot that it had been a little bit longer. I'd gone 5 months. I was like, oh, my wrists are really bothering me. Am I typing too much? Is it carpal tunnel? Yeah. My back. I'm like, why is it when I stand at my kid's soccer game, that low back is really bothering me? Pellet again, gone. So after maybe 3 or 4 pellets, I really figured out that it was my testosterone being low that was affecting my joints. And so I'm living proof that it's not just like, oh, maybe this will help. It does help.
Yeah. Yeah. And and it's so funny because I can attest, Erin was sort of a shell of a person when she started. It was really hard, I think, coming off of years of working in that capacity. And I also think too, not sleeping, chronic stress, all of those pieces aid. And we have to remember, right? There are lots of things in our lives that are going to decrease it's not just, yes, we're going to lose testosterone. It is a natural process, but there are lots of things in our life that also then suppress that even further. So chronic stress, not sleeping, certain medications, pain medication, pain in general. Nutrition is a big one.
I have really tried to work on
lack of exercise. So when people even start exercising even more, that can even just naturally start to boost those things. So I think it's important to sort of talk about, yes, life, like the things that we can change in our lives that are definitely going to help this process. And we're eventually going to get to a point, though, that it's not just those natural processes. We have to sort of add in those things that our body just physically is not making anymore. But it's been such a joy to sort of see Erin's journey through this time because it was sort of like bringing something back to life a little bit. Like it was there all along and we just had to sort of watch it flourish. So, and we've watched our patients flourish. And that's why I think this process has been such an amazing thing. We initially we started a lot with weight management, and then we knew that we wanted to do a lot more functional medicine. And this was such a huge and vital piece that is missing in our community. It is a lot of primary care there's just, unfortunately, even in medicine, we just don't learn a lot about hormones in general, about menopause. I think the menopause guide, even for physicians, is about this big, teeny tiny, okay? Like little blips. And so a lot of people just do not feel comfortable treating women through this. And I'm hoping that with sort of the movement that's going on, that this is going to change. And I hopefully that that we are educating one another and we're normalizing this so that women do feel empowered. They empowered to make these decisions. And if they're not getting what they need from a provider, that they're going to go somewhere else and they're going to seek this out. And just as a side note, your journey is going to change. Erin's journey in perimenopause and what she needs now, it already changed, right? It started with just testosterone. Then we needed to add this. Then when she finally hits menopause, we're likely going to need estrogen or we're going to need something else. And then during that time, when we've been postmenopausal for a time period, those doses might change. And so it's really important to find a provider that is gonna feel comfortable making those adjustments as your body is changing, because your body is gonna change. Our bodies are not a static being. We are constantly changing. So anything else, Erin, to add before we sort of hop into we can just read this, but hop into some questions as well.
This just talks a little bit about like
the benefits.
So you go on hormone therapy. We're going to see 75 to 85% of people say they improve with those vasomotor symptoms. What does vasomotor mean? Hot flashes, night sweats. 60 to 70% of people say they feel better, sleep better, moods better. Overall, they feel better. And then 80 to 90% of people their vaginal health has improved by 80 to 90%. With just local therapy, estrogen in the vagina, right? And so we talked a little bit about this. Early initiation within that 10 years of menopause really improves that risk benefit ratio for all, like your bone, your heart, and your brain. And I talk a lot in my consultations about like all-cause mortality, right? They really see that as your hormones come down, all-cause mortality, so every cause of death, you know,
It's
the
just
way we
going
die
up.
is going up, right? And so, and they do see that reciprocal change that when we give these hormones back, that this percentage of all-cause mortality goes down.
Yeah. Yeah, for sure. So thank you so much tonight for tuning in. I know that sometimes we can go off on some tangents and we can talk a lot, but we really wanted to just give you this a brief enough guide so that you have some little bits and some little pearls that you can feel comfortable with. And if there's any questions, please feel free to let us know, DM us, text us, you name it. We are here to sort of help you along in your journey.
Yeah. Are there any questions anyone wants to write into the chat
Before we
hang up and we can answer live? If not, thanks for coming.
Was there any questions?
There was one that came through. So someone had emailed a question prior to that said, my OB started me on estrogen and progesterone, but not testosterone. I'm not feeling great. Would I benefit from a consultation?
Well, absolutely. If you are on hormone therapy and you are not feeling your best, like how you were 10 years ago, 5 years ago, maybe it's something else. Maybe it's not testosterone. Maybe we're missing something else that we had talked about. Maybe it's your thyroid. Maybe it's your adrenals. Maybe it's your gut. Maybe it's something else, right? So I think if you're not feeling your best on the therapy that you are currently on, yes, testosterone might help, but it also might be something else. We should probably get to the root cause of that something else.
Yes, for sure. For sure. Another question that I get asked often is, how long can you stay on hormone replacement therapy? And we touched upon this, but there's really not a set time in which you're going to come off. So if, of course, there's something that's going on within your body that you or history or medical concerns that we have to take you off. But I think this was last summer, there was a really, 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 really big study. And this was with women over the age of 65 and well into their 70s and beyond. And women continue to do well on hormone replacement therapy. And there was no, what we talk about, cause mortality with them being on that. So,
and I have seen some studies that point out that you may have a little bit higher risk of developing a cancer, but those cancers that you do develop are less aggressive forms than if you were not on the hormone therapy, right? So, we certainly have a ton of studies available. So if you're interested in having any sort of literature sent to you, we have a ton of studies. I mean, there's hundreds of studies on hormones. There's a lot of studies on estrogen. There's a lot of studies on progesterone, some studies on testosterone. So, yeah.
Okay, this is great. So, and this is the thing too. So there was a question in here about, a woman going to 3 different specialists and it really hasn't helped. I don't know what those specialists are. And I think sometimes it's just different approaches, right? So I think this is why it's really important to take a very individualized look into what is going on holistically with that patient. We work very closely with other providers as well. I want to make that very clear. I think it's really important. There are some maybe OBs that they're just not super familiar with utilizing testosterone. And so that might be an extra added piece that we maybe do because they don't necessarily feel comfortable. So I always think it's so important to work as collectively as a medical community if we can. And then to add on to those pieces, it's not necessarily doing the same, it's not necessarily doing the same evaluation over and over again, but sometimes in perimenopause, when you're doing labs, it it's not always straightforward. And it's not always straightforward because there are some times when maybe a woman is still, maybe they have an IUD in place, or maybe they're still on birth control. And so when you're checking those levels of estradiol or you're checking a progesterone level, those levels are going to be a little bit wonky, right? Because they're getting a synthetic form. They're already getting a progestin, they're getting estrogen synthetically. And so the goal at that point might be, well, maybe we're just going to supplement them with maybe a little bit of testosterone, or maybe we have that conversation depending upon where they are in their journey. Do we maybe transition them off of those things, sort of reevaluate where they are, where are their labs at that time, and then make adjustments? So it's not sort of cut and dry. It's, yes, people might still want to be on birth control, and that's okay. It's just, what can we maybe add or remove, or how do we adjust those things throughout the process? Does that make sense, Erin? Like, would you add anything else to that?
I think that's right on.
And then, do you need testing to confirm if someone is in menopause?
Well, you're not technically in menopause until you have not had a period for 1 year. So when you've not had a period for 1 year, you can say you're in menopause. We use testing, so blood work, to sort of as a baseline. Where do we go from here? How do you feel? What are your labs doing? Are your labs improving while we're on this? And it's just like kind of a science, we use it as just a guide, because if you're feeling great and your labs are like in the normal range, maybe we don't need to adjust it, but you feel amazing. Great. But I do think that labs are useful in figuring out your baseline and then sort of gauging, if you're not feeling great, where can we change your therapy?
And then another question here: if I've had breast cancer, can I have hormone replacement therapy? So it's not straightforward. Every individual patient, it's going to be unique for them in terms of what type of breast cancer they've had, what type of treatments they've had. Are they on any current estrogen blockers at this point? So the short answer is, in some cases, yes, they can still be on hormone replacement therapy, specifically testosterone. Sometimes it is having a conversation with their oncologist to figure out if, in fact, that is appropriate. So it's not a straightforward yes or no. It's sort of in the middle, that for some women, it is 100% going to be appropriate to keep them on that. And then with the same prophylactic measures as other women would be. And then for others, it may be a hard no, just on the basis of what type of cancers that they have had.
So another person posted, my doctor talked about suggesting an IUD or birth control to help my current symptoms if they are hormonal. I don't want any of those options. So I think this is a really great question. I mean, it really depends on what are your symptoms. Are you having those irregular periods? Are you having mood swings?
Yep.
How old are you? So this is,
are you sleeping well? Like what is that other bigger picture in terms of what are our options?
Yeah. And I think, coming up with a plan that you feel comfortable with, that is going to address your concerns, is the most important thing. And that might be what your OBGYN has suggested, right? That might be the best option. However, we try to keep an open mind on other things that we can use if you are not like completely perimenopausal, to help with some of these symptoms.
Another question was, I had a patient today. This was a gentleman, but he was talking about hormone fatigue. Like, if you start this, do you have to be on it forever? Like, if you get pelleted, what is that like? Do I have to come in for labs every week? Is this going to be a huge commitment? And I thought that it was actually a really interesting question, because I get that, right? You start on something, and do I have to sort of commit to this long term? For the most part, if you're starting on something It's a commitment because you feel better and you want to continue that. What does that commitment look like? If you stop hormone replacement therapy, your levels are essentially just going to trickle down and you're going to end up back where you were. And then you just figure out, okay, do I feel terrible and do I need to do this again?
And in my experience,
that's when people
really kind of see, like, I think what some of my patients have said, I don't really know if I feel a difference, right? And so the plan is, well, why don't we'll stop and see how you feel, right? If they say they don't want to go on anymore, okay. And my experience is, holy cow, I didn't realize that I needed this. And they typically will want to do get back on something. Does that mean you have to? No.
And labs really should be convenient. We like to monitor our patients closely. It's going to be a little different depending upon what type of therapy. If you're starting on topicals, we might repeat your labs in around 3 months because you need to give that a little bit of time. If you're on injectables, we'll likely recheck you at a month because we want to see where you are and if we have to dose adjust at that point. If you're on pellets, we like to, in our office, every practice is going to be a little bit different in terms of what they want to do. We particularly, though, like to check a peak level at around 4 to 6 weeks, depending, and then a trough. And that trough means, where is that going to be at your lowest point? Everyone, and I don't set that anymore. I used to say, okay, at 12 weeks, we're going to check a trough, or at this point, we're going to check that. I actually want to know when a patient feels like they are at their lowest, where they feel like, whoa, I am really feeling a shift and I'm really feeling a change. That's when I want to check that, so that way I can sort of see when they felt the worst or when they were really feeling that go down, what is that level? And then we can determine, okay, are you still high? Do we need to wait another month before we repellet you? Or do we need to, because what we don't want to do is have people coming in and maybe they started here and then their level went up to here. And then that dropped to here, but then you pellet them again. And so you sort of kind of get a stacking effect. You need that level to sort of come down enough where, okay, we've dwindled down and now we're going to repellet. We're never going to we don't want someone to go all the way back down to where they started, because they're going to feel horrible. But you want them on that downward curve, so that way your doses and your levels are not getting too high. And so that's really why we follow our patients closely.
What other questions? Does anyone have any more questions?
And do you want to just remind them about the special if they do book?
Sure. Jess, okay, you can hear Jess in the background. Jess is going to tell us. So
anyone who books that was on the webinar will save $150 between their consultation and labs.
Perfect. So that's a big savings.
So
Normally,
just let us know when you call to book, or if you book online through the event.
Yeah. So again, we just wanted to thank you for sort of sitting in. We know it's a lot, and we hope that we can help you on your journey in the future. So again, thank you. We are always here. If you have questions, you can always DM us or email us. And thank you again. It was a pleasure being able to do this for you all, and we hope that you have a wonderful evening. Bye, guys.
Bye. Oh my God.
Wait, we're not ended yet.
Erin, you did great. Erin's favorite thing is public speaking.
And social